You guys can all hear me okay, right? Good morning. Good morning. So I was born as a professional in the high-tech era. It was an extraordinary time for a lot of us, if you remember, for some of those that have been around that long. On the heels of the Great Recession, I had my shiny new college degree, and I set out to make the world a better place. I earned my degree in public relations with a passion for healthcare communication specifically, and what a time was it to be a professional in the space. In 2010, the high-tech era was burgeoning, and meaningful use was taking off. Things like the e-patient started emerging. If you remember the Blue Button Initiative, that was another fun project from that era. And most of us at that time were also preoccupied with moving physicians away from paper records over to using computers. Early on as well, ACOs came into the picture. I remember writing a post about this alphabet soup of acronyms that we've all become accustomed to at that time. And broadly speaking, that era really brought around attention from this idea that point-to-point interfaces were really the architecture of integration at that time. Simultaneous to all of this movement and exciting activity on the health tech front, there was an emerging industry as well happening. That was social media. So at the same time, things like Facebook were taking off, and businesses were trying to make sense of how do we live in this world of social media? Isn't that just where people share pictures of their lunch, for example? Well, it wasn't. And Gen Y emerged from this era as well. It was a new generation of professionals shaking things up. Twitter became a news source for things, whereas typically, as we all understood at that time, most of the news we gathered was from mainstream media. But this exciting new technology was introducing a whole new element to our day-to-day life. And also very interesting at that time, if you reflect back, in 2010, Twitter also was limited in the number of characters that it had. And so architecturally, it was built on this idea of RSS feeds rather than the algorithms that we've become so accustomed to today, which also meant that most of the content was chronological. And what was very exciting is that that architecture brought about the space for us as a community to start collaborating with one another. So as all of this exciting movement was happening in the health IT front, in social media at the same time, physicians even were meeting with one another. And patients, in some cases, were also meeting with one another and talking about this future of healthcare that was evolving very rapidly. In that era, there were also a community of HCSM people, stood for healthcare social media. But there was a voice missing from that conversation. These were physicians, these were administrators, these were influencers in the healthcare space meeting, but the IT professional didn't really have a seat at the table in terms of that conversation. So in 2010, as a new grad, I had just accepted a position with an integration engine vendor, and my job with them was to help them figure out how do we make sense of the social media world relative to the interoperability space that we have here in healthcare. So inviting the IT professional voice to the conversation, I founded a community called HITSM, which stands for Health IT Social Media, and it really became quite an amazing community. I'm seeing some nods. Dee Dee's in the audience. She remembers that era. John in the back, also our legacy influencer of that space. But there was a lot that we learned from that era. There was an exciting time, a lot of relationships built, a lot of people came from that space. But I think there was something really remarkable that happened that I don't want to lose sight of as an industry as we look ahead and move forward and consider things like AI influencing the space that we're in today. So there's things that we can learn, right? As professionals in this space, there are things that we can build upon around the communities that emerged from this world. And when you build a community, there are foundations that exist. Things like be consistent and reliable, predictable. So in that time, we founded the Twitter chats, HITSM, that met every Friday, or every actually Monday evening, and we got together and congregated around what the future of health IT held. Things also like being relatable. That meant being involved in the chats, in the community, really just leaning into that space entirely. Also recognizing excellent contributions to the community. Part of what allows communities to grow around movements in particular are that people that contribute meaningfully to that world need to get recognized for those contributions. And then also just leading through service, not ownership. So no one of us can actually own the future of interoperability in healthcare, of course, but we can all serve the mission and vision of that space. So as I was leading these conversations, there were several influencers that emerged, and these folks have really gone on to build incredible careers today, all with their own stories anchoring a lot of that movement because they showed up as individuals and showed up as themselves. And one of the things that stood out to me at that time, even for myself and reflecting on why do I have a spot in this conversation, why do I deserve to be in this table, I suppose I was a patient. And so there was an element of that influenced my leadership in that world. But I had my own patient stories too. I kind of struggled with eczema and asthma most of my life in my childhood. And around that time as well, had also encountered an experience with alopecia, which is another form of an autoimmune condition. And those things, for the most part, colored my world and really influenced my perspective of what my story was, because I thought that was what it was. But fast forward about 9 years, and my story was actually just starting, and I didn't realize this at the time. But in 2019, so 9 years later, I had my second son, August, who at 5 months old was diagnosed with an aggressive form of brain cancer. My life got turned upside down. I thought I knew what data interoperability was. I thought I knew what healthcare was. I had been working in this industry for almost 10 years. And in a blink of an eye, literally, my 5-month-old son put all of my work as a professional into perspective because it became immensely personal in that space. We were planning a cross-country move for our family, really as a Hail Mary. We had just, 5 hours earlier before we found the tumor, had sold our home in Dallas, Texas, and we had planned to move across the country. When your life changes like that in those moments, they can be disorienting, but they can also be incredibly recalibrating. But one thing stands out, and that's that lived experience is absolutely the blueprint for how we experience healthcare in this country especially. We cannot ignore the realities that come with a patient who winds up with a diagnosis. It is more than just an individual diagnosis. When someone hears the words, they have cancer, it's not just in an isolation, it's not a mechanical thing that happens. That is a human being, and they have a lot of life happening around them in that moment. That individual might have just been served divorce papers, and then they receive that diagnosis. They might have just sold their house, like was the case with us. They might be struggling in a job and on a performance improvement plan and trying to hustle and grind and figure out how they're gonna make their career survive, and then get sideswiped with a diagnosis like that. Those contextual experiences absolutely influence the health outcomes that we ultimately have access to, which is why lived experience has to help inform the innovation that we have as an industry going forward. There's a lot of pain points that exist as well in the patient and caregiver journey today that are low-hanging fruit opportunities for us that have a huge ROI and may or may not even be technically driven or technically inspired. So in our case, in our journey, when my son was encountering his several years of treatment. Immediately after diagnosis in 2019, I was even just trying to figure out, how do I solve for a simple medication issue? And that was keeping track with my husband at the time of who gave my son which medication. And we got discharged from the hospital, and they said, the best solution we have for you, Erica, is to put a notebook on your kitchen island. There was no PHR. I even attempted to try to find some sort of health record or some sort of technology solution that might be able to help us manage the medications, but there wasn't one. And this pain point was actually pretty excruciating, because there are things like acetaminophen and context to HiSet. If you give both of those medications, you're actually duplicating acetaminophen because it's included in the HiSet. You wouldn't know that necessarily unless you have something helping inform you along the way. So the notebook is one great example of an opportunity that we can use to innovate that's based on that lived experience. Another pain point that we encountered when it came to perhaps data was the experience of trying to get a second opinion. And so when my son went through his initial treatment, we were able to achieve NED status, which was incredible. After 4 rounds of chemo and a couple surgeries, but we unfortunately did have to encounter a recurrence at one point. And so the team, our local team, told us that the tumor was inoperable, and that wasn't going to be a solution for us at that point. So we sought out second opinions, found a surgeon at Boston Children's who effectively said, this is a chip shot surgery, I can do this. And so we packed up and we went to Boston, and the surgeon was able to accommodate everything that they needed. But as a child coming from Texas, who both had a private and public insurance plan helping support the care that he was receiving, there's a lot of complexity with moving data from one state to another and making sure that you have a medically complex child who's now crossing state lines and having to get approvals and having to go through that process. Thankfully, we had, consistency in the EHR involved. So both our home health system as well as Boston both use Epic. So we were able to coordinate a little bit more effectively between those two systems, but contextually, again, there was a lot of information that my son carried with him as a part of his complexity that probably was not truly reflected in the medical records that he continued on with in Boston. We encountered another data exchange pain point along the way as well. And this is, I think, a great example of where innovation really becomes meaningful. So, of course, we're all very and incredibly excited about what's ahead for us in artificial intelligence and all of the potential and opportunities that exist with that technology alone. But what we encountered was, oh my gosh, there is an opportunity for this technology, perhaps, to help inform us in our decision-making when it came to care planning. So my son, unfortunately, had another recurrence on the brainstem, which is where the original tumor location was, and we had exhausted the standard of care at this point in our journey. And so we found an AI startup that was willing to do image analysis for us on MRI imaging. And they were going to help us differentiate between necrotic tissue and proliferating tumor progression, which is a very critical piece of information. If you are outside the standard of care and you want to know, is the thing that we're doing or what is it we're doing, is it actually working or not? And are we moving in the right direction? So working with this AI startup, they said, hey, Erica, this is fantastic. We'd love to work with you. Upload the images to the secure file that we have, or the secure server. Here's all the instructions, and we'll be in touch. Seems like a simple problem to solve, until you realize that you don't, in fact, really control your own data, especially imaging data, and having to get those images then uploaded in a way that may exist outside of the standard workflows that they have as well with their data exchange. So what seemed like a simple data sharing opportunity with a huge return on investment potentially, actually became a big barrier for us. And so this critical piece of information became a 3-month-long ordeal trying to get imaging from radiology uploaded to a server, very simple instructions, even going through the channels of medical record sharing. Thankfully, we were able to get it uploaded. Now there was a limitation in the AI technology, but it still took us 3 months to do something that should not have taken us that long. So also in the spirit of AI, there was another pain point that we encountered, and that's that nobody really, at the end of the day, owned the care coordination of my son's care plan. There were a lot of specialists involved in his care planning process. We had palliative care, we had oncology, we had a medically complex pediatrician involved in his care as well. But all of these folks, although they play nice with one another typically, they're not in a room actively with one another strategizing about what this care plan should look like, especially after the standard of care had been exhausted. And so when we had encountered another roadblock in our care journey and we were trying to figure out, okay, what can we in fact do outside of the standard of care? What other drugs might be repurposed potentially for my son? What other options might exist? Is there targeted ultrasound? Are there other things like that emerging from the space that could provide opportunity? And what we did need to do, though, in order to actually get alignment among all of these specialists was to hold a care conference. And so one thing that became a pain point outside of just coordinating that care was how do you actually, in fact, go about executing on this as a parent and having to coordinate all of this? Because, again, nobody in your care team effectively is going to take ultimate ownership over the end-to-end experience of care. So at the same time as all of this was happening, ChatGPT was becoming a household name, and it became my new best friend. So I used the technology to help design and coordinate an agenda for a care conference with my son's care team, at least the key players that we needed involved in involved with decision-making after that standard of care had been exhausted. And it worked miraculously because otherwise, the executive function required for me to execute on something like this at that time, as I'm being a parent and emotionally invested in my son's care, it would have taken so many hours and so much energy, it would have exhausted me emotionally and intellectually. So I was able to outsource some of that to ChatGPT, and it helped coordinate care and streamline that. That was one other pain point, right? And then the other pain point that I think is really important to point out, and this is outside of even some clinical workflows, and that's that the pain of our systemic problems today in this industry don't stop once the care has been delivered. So today, there are plenty of other workflows in our experience that reflect the things that happen in clinical integration and interoperability. In this case, my son's managed care provider sent me a text message about 3 months after my son unfortunately passed away. And they duly wanted to remind me that they were trying to reach me about scheduling my son's annual wellness visit. This is a systemic breakdown where data that's happening clinically and in the workflows that we're all accustomed to and familiar with day to day is getting translated out and used to help inform things like marketing initiatives. And they're failing because this type of encounter is more than just a systemic breakdown. This is additionally triggering for people that were invested in this case, my son's care. So what I want to make sure comes through is that historically, right, innovation has remained, for the most part, a point-to-point environment. We have looked at solutions as very transactional as an industry. However, our system and economy of healthcare fails when it can't hold the other dynamic points in that system accountable to what we need them to be accountable to. So historically, this has looked like this wonderful people, process, technology, three-legged stool, We have had wonderful innovations come from this space where we've looked at this balance very intentionally. However, this workflow or this framework doesn't hold water and doesn't hold up in the current environment, both with the rate at which technology is evolving, but also it doesn't honor the most important component of really healthcare today, and has always been the most important part of healthcare, and that's the lived experience of care. So that three-legged stool can't work anymore for us. We have to look at lived experience as a catalyst and an information point for the innovation that comes from our industry and where we're at today and going forward. Because that lived experience is integral to the things like technology that are evolving. The systems might be both the care plans, but also the integration workflows that exist. And equity is more than just let's make sure everybody has access to the same things. Equity is about making sure or honoring that every patient that comes into our healthcare system has access to the same health outcomes as any other patient. And I think that is a monumental task that we have to have in mind and in the forefront of our mind as we make decisions. So a lesson for all of you, right? We have to begin with that lived experience. We can't operate from this space of hypothetical scenarios where we pretend to know what the patient experience looks like in a very simple way. Every single patient that comes into the hospital, even the most simple ones where you might have a child with a broken arm who fell off the playground and gets admitted and gets their arm reset, they get ordered PT, they go back home, and everything's great. We can't operate off of one-dimensional patient experience scenarios any longer. We have to look at that entire human being. So that one patient who comes in with a broken arm, what is their parents like? Are their parents divorced? Are they together? How is their social environment supporting their health outcomes? How are they going to coordinate the physical therapy that's ordered ultimately? There's so much more to that patient than just the clinical definitions that we're ascribing to them. We also cannot shy away in the same spirit of complexity. So when we look at complex scenarios and that lived experience and the complexity of lived experience, if we can use those stories to help inform the innovation, it actually makes our systems stronger and the technology stronger and the equity programs and those initiatives even stronger. Finally, the other point that really became especially poignant as my experience as a caregiver is that emotional safety is no longer a nice to have. We as a society have to continue cultivating a sense of emotional safety in the work that we do, even if it doesn't feel very logical at the time. That trauma-informed care, trauma-informed is a clinical definition that exists, but it's no longer optional. We cannot pretend like the emotional well-being of our patients and those care populations are not important any longer. And this is really critical because it connects to the health outcomes that patients ultimately experience. So what we've learned, or what we're learning about the impact of trauma and how our brains work, is that when you're experiencing something like a stressful event, for example, you find out you have a really horrible diagnosis like cancer, your brain responds differently to that information from that point forward. In that environment, the brain can't compute certain information like it would if it was feeling safe and comfortable and rested. This impact of trauma on the brain's function typically impacts the executive function of the brain more predominantly compared to other functions. These things, though, typically are connected to how we've thought about things like patient engagement and patient empowerment. These are functions like self-regulation, problem solving, impulse control, following instructions. Those things are inaccessible to a brain that's experiencing trauma real time. So it is inappropriate for us as an industry to expect that patients would engage with their health care in this manner. And so this function and this reality is something that I really would love to challenge all of us as professionals in this space, and looking at how do we support healthcare going forward and innovation going forward. It's embracing those stories, but also honoring this reality that our cognitive experience of care is unique when we're experiencing trauma. And we have to, as a system, honor that reality for us to get the best possible outcomes from those patients and the caregivers supporting them. So there's like I mentioned, there's a clinical definition around trauma-informed that exists today. I will not pretend to be a therapist by any means, or a professional, but certainly a very big fan of this model, and looking at what lessons can we actually learn as an industry from supporting a trauma-informed approach. Well, when we look at these in context to innovation, I think that there's some really wonderful opportunities that can emerge from that as well. So phase one, before you do anything with trauma, the first priority has to be establishing safety and stabilizing the circumstances. So you tell somebody that they have a cancer diagnosis, what can we do to help them restore a sense of safety as quickly as possible? Because the faster we can do that, the faster we can actually get them to being able to problem solve and engage in their care more meaningfully. Further, beyond the stabilization, then there's experiences of remembrance and processing. These are things like validation. And then tertiary to that is integration, reconnection, and rehabilitation. So I want to offer an example of where this actually comes in, because lived experience, although it can be incredibly messy, it also can be quite beautiful. And so one of the things that I encountered as a caregiver with my son when we were in the hospital, part of our lived experience was the opportunity to color pictures on the hospital room door of my son's rooms that he would have in the hospital facility. Every time we'd have an inpatient stay, I would draw a picture on his door. And it was one morning, it was 3 o'clock in the morning, one night. I was on the oncology floor, and I was drawing the Wally picture on the bottom left there. And I was contemplating my son's mortality, and I said, what do I do if my son survives and we want to give back to the community? How do we go about doing that? And if he doesn't make it for some reason, how can I honor his legacy? I learned that these window crayons were being paid for by the nurses on the floor. And that's not to say that the hospital didn't prioritize something like access to art supplies. It just wasn't a priority for their facility, and it didn't connect necessarily one-to-one to the health outcomes that their patient populations were receiving. But it was still important, and it was actually a very critical and looked forward to component of most inpatient stays for a lot of the families in this environment. And so what I did is I founded a nonprofit that could honor my son's legacy and help make sure that families across the country have access to these art supplies, but also in the spirit of that trauma-informed approach, honor and commemorate the artwork that's made so that the families could, in fact, bring that home with them after they were discharged, because they can't bring that artwork home on the window itself. So we created a nonprofit called August Artists. It was founded a few years ago, and we've expanded already to 4 facilities across the country, with hopes and vision to expand to all the pediatric hospitals across the country at some point. But what we do is we donate the window crayons, and then we commemorate the artwork that the families make, and of course support that trauma-informed, family-centered, outcomes-based care vision that I think we all share collectively. So my final comments to all of you, as you think about the sessions ahead for the day and you go back home and you think about the work that you're doing, I want to just remind you all, as somebody who has both worked in this space as a professional, but also has lived in this space as a caregiver and a patient. Innovation does not have to only be technically driven. It does not have to only be technology. Although those are exciting and interesting, they don't have to be the only innovation opportunities that exist. Also, complex patients are your use case gold. Start with complexity, start with real lived experience. If you start there as your use case framework, all of the technologies and solutions in theory should be able to capture your most complex patients in your population. Also, historically, we've only ever looked at the outcomes of the individual patient, but I would like to challenge all of us about what that actually means, because if our patient survives and they wind up with good health outcomes, but the people surrounding that patient who are responsible for helping to support that patient's outcomes don't make it. If they have chronic health issues that emerge, they wind up with PTSD, they wind up with having debilitating issues emerge from just the function of caregiving, were we really that successful? And then finally, I want to remind all of you, those stories, they matter. Those actually, in fact, heal, because they're a part of that validation. It's the stories we tell ourselves. It's also the stories we tell others about our journey as patients and as caregivers. These experiences are critical for us as an industry to use as a framework, as inspiration for us moving forward. And these problems, I want to leave us on one final point, that we've been talking about a lot of the same things for the last 15 years. When I started in this space, in the high-tech meaningful use era, we were talking about empowered patients. We were talking about data ownership. We're still talking about the same things. It's a sobering reminder of the work that we're doing. However, we should have a shared sense of urgency in solving these problems today, so the next generation of leaders who come in can solve better problems. So thank you.